right, let's talk about acute bacterial meningitis. This is one of those topics you absolutely have to know for your exams. So we're going to skip the fluff and get right to the high-yield stuff, the things that are going to help you ace those questions. We'll break it all down so you can walk into that exam feeling totally prepared. Okay, here's how we're going to tackle this. First, we'll look at a classic case. What does this patient look like? Then we'll figure out the usual bacterial suspects. After that, we'll dive into how they breach the brain's defenses. Then comes the definitive diagnosis, how do we prove it, and finally, we'll cover treatment because we're racing against the clock. Let's get started. All right, section 1, a classic case. You need to recognize the telltale signs because I guarantee you this is exactly how they'll present it in an exam question. So picture this. A patient comes into the ER. They've got a fever, a killer headache, and a really stiff neck. That's the classic triad. And when you see that, especially the stiff neck, what we call nuchal rigidity, your brain needs to light up with one word, meningitis. It's the biggest clue they can give you. So what exactly is meningitis? Well, it's a nasty, pus-forming infection. That's what purulent means, of the leptomeninges. Now, those are the delicate inner layers that wrap around your brain and spinal cord, the arachnoid and pia mater. The infection happens in that space, the subarachnoid space, and it's that intense inflammation that causes all those horrible symptoms we just talked about. And check this out. There are 2 classic physical exam signs you have to know for this. First, you've got Koenig sign. You flex the patient's hip, then try to straighten their knee, and it's super painful. Then there's Brudzinski's sign. You just flex the patient's neck forward, and watch this. Their hips and knees automatically flex up. Both of these are screaming meningeal irritation. They're practically pathognomonic, which is a fancy way of saying if you see these, you can be almost certain you're dealing with meningitis. Okay, so we're pretty sure it's meningitis, but who's the culprit? Let's move on and identify the usual bacterial suspects. And listen up, because knowing which bacteria to suspect based on the patient's age, that's pure high-yield gold for your exams. So if you look at all cases combined, the undisputed heavyweight champion is Streptococcus pneumoniae. It's responsible for about half of all cases, but there are 5 major players on this list, and you've got to know every single one of them. And of course, we've got a mnemonic to make this easy. Just remember SMSLH. That's S for strep pneumonia, M for meningococcus, S for strep agalactia, L for listeria, and H for haemophilus. SMSLH. Super simple. Just lock that into your brain. Now, this is where they try to trip you up on exams. The bug depends on the patient's age. It's not the same for everyone. For newborns, you got to think about bugs they can pick up during birth, right? So things like strep agalactia, that's group B strep, E. coli, and listeria. And speaking of listeria, this is key. For the very young and the very old, you always have to have listeria on your radar. I promise you that gets tested all the time. All right, so how in the world do these bacteria get into the central nervous system? I mean, it's supposed to be a fortress, right? Let's break down how they breach the barrier. It's basically a 4-step heist. First, the bacteria set up a base camp, usually colonizing the back of your nose and throat, the nasopharynx. From there, they launch an invasion into the bloodstream. That's step 2. Step 3 is the big one. They have to breach the blood-brain barrier, the CNS's security wall. And once they're in, it's step 4. They multiply like crazy in the subarachnoid space, which triggers this massive, dangerous inflammatory response. So, who's most at risk? Well, age is a huge factor. Newborns and the elderly just don't have the same immune firepower. Vaccination status is another big one. The HID vaccine, for example, was an absolute game changer for reducing H. influenza meningitis. And then you have to think about anyone with a compromised immune system, maybe from alcoholism, diabetes, or, a classic exam favorite, someone who's had their spleen removed. Oh, and don't forget anatomical defects, like after a head trauma or surgery. That's like leaving a back door open for the bacteria. Okay, we've got a strong suspicion, but suspicion isn't enough. We need proof. And for that, we need to do a lumbar puncture to get a sample of the cerebrospinal fluid, the CSF. This is where we get our definitive diagnosis. Pay close attention here, because this table is pretty much a guaranteed exam question. When you look at the CSF in bacterial meningitis, a few things jump out. The pressure is way up, the white blood cell count is through the roof, and it's almost all neutrophils, the body's first responders. But here are the 2 most important things. The glucose is super low. Why? Well, because the bacteria are in there having a party, just gobbling up all the sugar. And the protein is super high from all the inflammation and dead cells. So remember this, tons of neutrophils and super low glucose. Burn that into your brain. So the first thing we're going to do with that CSF is a gram stain. This is our first, fastest clue to who we're dealing with. I mean, we can get an idea in less than an hour. And knowing these classic appearances, like what you see in this table, is incredibly high yield. You see gram-positive lancet-shaped Diplococcus? You're thinking strep pneumo. Gram-negative Diplococci? Neisseria. This is absolutely vital for starting the right antibiotics right away. And take a look at this. This is exactly what you'd be looking for. See those little red guys? Those are gram-negative bacteria. And notice how they're in pairs, kind of like little kidney beans. That's the classic Diplococcus shape. And look even closer. You can see them hiding out inside a neutrophil. This picture is screaming Neisseria meningitis at you. Okay, the gram stain gives us a great head start, but we need to confirm it. The gold standard is always going to be culture, growing the bacteria on agar. The problem? That takes a day or two, and we don't have that kind of time. Luckily, we have faster methods now, like latex agglutination tests or the real game changer, multiplex PCR, which can give us a name in just a few hours. And, pro tip, always get a blood culture too. The bugs are usually in the blood before they get to the brain, so it's another good way to catch them. All right, last section and arguably the most important one. Treatment. Because now we're racing the clock. I cannot stress this enough. Bacterial meningitis is a massive medical emergency. Every single minute counts. We have to act, and we have to act fast. So here's the game plan, and it's non-negotiable. You start empirical antibiotics immediately. As soon as you get that CSF sample, you start the drugs. You do not wait for the lab results to come back. It's a shoot first, ask questions later kind of situation. Your choice of drugs is a best guess based on the patient's age. So for most adults, you'll hit them with a combo like ceftriaxone and vancomycin. But wait, if they're older and you're worried about listeria, you have to add ampicillin to that. For neonates, it's a different combo entirely, usually ampicillin with gentamicin. Then, once you get the culture results back with the specific bug and its weaknesses, you can switch to a more targeted antibiotic. And this is why we're so aggressive. Look at these numbers. The mortality rate is terrifyingly high. And even for those who survive, up to half of them can have lifelong complications, deafness, seizures, brain damage. You have to remember the mantra here. Time is brain. Every second you wait, more damage is being done. Okay, let's wrap this up with one final super high-yield takeaway. If you get an exam question that asks you to tell the difference between bacterial and viral meningitis just by looking at the CSF, what's the dead giveaway? It's two things, the cells and the sugar. For bacterial, think neutrophils and no glucose. The neutrophils rush in, and the bacteria eat all the sugar. For viral, think lymphocytes and normal glucose. If you can just remember that one key difference, you're going to be in great shape for your exams.